Good evening, everybody. A warm welcome to ILD Webinar Series, which is organized by Indian Chess Society. And we have a fantastic topic today, which is so very common, yet it is really a huge challenge for us to diagnose as well as treat. The topic is nothing else but idiopathic pulmonary fibrosis, the best approach. And we are really lucky that for today's webinar, we have star of a faculty, the faculty which is doing the best possible work in IPF, and they are best read, they are academically most advanced and most updated, and they are going to tell us how ideally we should be dealing with our patients who are suffering from idiopathic pulmonary fibrosis. I'd like to first introduce moderator of our today's webinar, our captain of the ship, Dr. Rakesh Shavla, my very dear friend who requires no introduction. Not only our country, but the entire world knows him. As we all know, he is a president-elect of Indian Association for Bronchology. He is on the board of regents of WOBIP, the International Bronchology Society. He is the vice president of Indian Chess Society, and he is the one who made the thoracoscopy guidelines for India. He recently did a NAPCON 2023. He's written so many chapters, so many publications. If I talk about him, I'll continue till tomorrow. So I think I'll end here. Over to you, Dr. Rakesh Shavla. We look forward to the academic treat.
Thank you, Amita. I think this all work and the credit goes to Dr. Amita, who is the chair of TEI. I think she is telling about Dr. Chawla, but the world knows about Amita. The country knows about her. The whole force behind, we in Indian Chess Society were all requesting her, give some pause, give some gap. No, she said, I will show how I do, and she has written the history of the webinars and how the webinars should be done. And in spite of doing IAB webinar, ICS webinar, 2, 3 webinars in a week, in a go, I think God bless her for the energy she has.
Thank you, sir.
Thank you, Dr. Salvi, Dr. Rajeshwarankar, Dr. Rajadhar, the people of Indian Chess Society. And I have been duty bound to thank CIPLA as an academic partner to the Indian Chess Society. Right. So now I will invite our first speaker, Yuvarajan, very close friend of mine, very close to my heart, and he is professor and head and secretary association of pulmonologists in Puducherry. He is an outstanding pulmonologist with Pulmo Sleep Me 2019 award from Health Secretary of Maharashtra. He is the Best Academician Award 2021 from CEGR Delhi. He's invited faculty to various state and national conferences. He organizes scientific symposium, scientific quiz every year in my Respicon. He is the invited faculty in ERS for the past 2 consecutive years. He is coordinator of ERS workshops in difficult intubation. He is invited faculty for Chess 2023 held at Hawaii, presented various papers in national and international conferences, publications and books and chapters, 78 books, 4 chapters, and various publications he has written. Welcome, Yuva, on board. Now, after introducing Yuva, now I have to invite our first speaker of the day, Bhavin Jhankaria. His introduction slide is not with me. He is the owner of Imaging and Beyond, and he is a renowned radiologist, radiopulmonologist of the country. People love to hear him. His talk is recorded. So I will request the CIPLA academic partners to run his talk.
Hi, welcome to today's topic of IPF. This is Dr. Bhavin Jhankaria, and today I will spend the next 18 to 20 minutes talking about idiopathic pulmonary fibrosis, and we will tackle the signs, conditions, variant fibrosis and NSIP, and protocols. So fibrosing ILD is typically can be diagnosed when we see one or more of these signs. So these reticular opacities are lace-like subtle opacities that we see typically in the subpleural interstitium. In the presence of reticular opacities, when we see traction bronchiectasis, that tells us that there's a fibrosing ILD, and the presence of cysts with shared walls, again, starting in the subpleural interstitium, extending up to the hilum, would be suggestive of honeycombing and is a strong sign of a fibrosing ILD. We also have signs of non-fibrosing ILDs with ground glass, consolidation, septal thickening, ill-defined nodules, and discrete nodules, some of which I've covered in the earlier talks on hypersensitivity pneumonitis and sarcoid. And these may occur along with the fibrosing ILDs, and we'll see that in a little while. So let's look at each individual sign and then see how all of these come together to allow us a diagnosis of IPF. So let's look at honeycombing. As I said, cysts with shared walls starting subpleurally, usually multiple layers extending up to the hilum. And you can see that really well, including the non-dependent honeycombing. Now, honeycombing is a specific sign, not very sensitive. Not all patients with IPF will have honeycombing, but when it is present, it tells us that there's a fibrosing ILD and there is a likelihood of IPF. And therefore, it should be differentiated from other conditions that present with holes or cysts in the lungs. And this is the list here. Let's run through this. So when we have cystic areas that are going from the hilum to the periphery and branching, then that would be bronchiectasis. If we see centrilobular lucencies without walls, then that's centrilobular emphysema. And you can see that same image of honeycombing on your left-hand side. Paraseptal emphysema will have just one row of cysts. Cystic lung disease presents with thin-walled cysts that are randomly distributed throughout the lung parenchyma, and traction bronchiectasis may be mistaken for honeycombing sometimes in the axial images, but when you look at the sagittal and or the coronal, you should be able to make out traction bronchiectasis well. So that brings us to traction bronchiectasis, where we're seeing reticular opacities, we're seeing traction bronchiectasis, we're just not seeing honeycombing. But this is a fibrosing ILD, and this is also, as I will tell you in a little while, suggestive of a UIP/IPF-like pattern. And again, on the sagittal images, we can see the areas of traction bronchiectasis. Well, it is a very sensitive sign. And when it is present, it implies a fibrosing ILD, except in acute settings, as we learned in COVID-19. So when we saw these bad areas of supposed fibrosis because of traction bronchiectasis, we started talking about how we're going to have an epidemic of people coming in with bad lungs. But you can see here 9 months later, almost everything has gone. So the valuable lesson here is that in the acute lung injury setting, traction bronchiectasis is reversible, but in the chronic setting, it's not. Reticular opacities sometimes are a little difficult to appreciate. These are linear opacities forming a net-like appearance, usually starting at the pleura or extending up to the pleura. And here, in fact, you can see very subtle traction bronchiectasis as well, but sometimes you may not see that. And the term reticular opacities encompasses the terms intralobular interstitial, interlobular interstitial, and septal thickening. So when the reticular opacities have traction bronchiectasis or honeycombing, these are easier to understand. But when they occur on their own, sometimes it's a little trickier to be able to figure out whether they are real or whether they imply interstitial lung abnormality or interstitial lung disease. So then we put the signs together. If you have reticular opacities with honeycombing and traction bronchiectasis, subpleural basal predominance, and nothing else, then that's our typical UIP pattern. reticular opacities, traction bronchiectasis, but no honeycombing and nothing else is the probable UIP pattern. And when we look at the 4-bucket classification that both Fleischner and ERS ATS came out with, both of these are suggestive of IPF, and a surgical biopsy is not indicated in the correct clinical setting. Now, UIP without etiology means idiopathic pulmonary fibrosis. But as in this 27-year-old with what looks like a typical UIP pattern, if you have esophageal dilatation and the patient has scleroderma, then it's scleroderma ILD with a UIP pattern. Or this patient who has a fibrosing ILD looks like probable UIP, has pleural calcified plaques, worked in a brake lining factory, has asbestos ILD with a UIP pattern. This patient has a fibrosing ILD with traction bronchiectasis, UIP-like pattern, but the patient had golden hair, had abnormal eyes. So this was Hermansky-Pudlak syndrome. So these are not IPFs, they are just UIP with an etiology. Then we have the UIP-like but non-IPF pattern. So if you look at this patient, there is honeycombing, and you might say, okay, we're looking at a UIP pattern. But as we go higher up, we see that there is an axial distribution from the hilum to the periphery. There's ground glass. We see ill-defined centrilobular nodules. There's also a lot of upper lobe fibrosis. So there's much more happening than what we saw earlier. And in that setting, we would say that while this is a fibrosing ILD, this is non-IPF, and this pattern is commonly seen with fibrotic hypersensitivity pneumonitis. And in that context, when we see the triple density signs, so normal lung, lucent lung, and ground glass in the same image, that gives us a little more confidence in making this diagnosis. Now, when we have reticular opacities, I mean, this is a fibrosing ILD with honeycombing and traction bronchiectasis, upper and mid-zone predominance. The basal regions are almost spared. We know it's a fibrosing ILD, but clearly this is the non-IPF pattern, and this is most commonly seen with chronic pulmonary sarcoid. So that gives us our last bucket here, where we see a fibrosing ILD, but we can see that it's not suggestive of IPF or suggestive of a non-IPF etiology. And here some more workup is often required, including BAL or surgical lung biopsy, etc. Now, there has been some thinking that if there is progression, especially with the non-IPF conditions, it may not be clinically important to differentiate among these buckets, because you could anyway just start antifibrotics. And so progressive pulmonary fibrosis was defined in a 2022 paper. And these are the 6 radiologic criteria. You also have clinical criteria to use. And clearly between 2016 and 2021, over 5 years, in this patient with fibrotic HP, you can see significant progression of the reticular opacities, honeycombing, traction bronchiectasis, etc., telling us that this is progressive pulmonary fibrosis. Another pattern of disease, and which we're recognizing more and more now, and likely will get its own bucket in future guidelines, is that of variant fibrosis. So we see a fibrosing ILD, but then we see other signs that point us towards connective tissue disease, ILD, and these include exuberant honeycombing, heterogeneous lung destruction, anterior upper lobe sign, island-like fibrosis, four-corners sign, straight edge sign, low attenuation areas, etc. So let's quickly look at these 5 of these signs. Exuberant honeycombing, commonly seen with rheumatoid arthritis ILD, is when we see honeycombing and cysts involving more than 70% of a lobe. The anterior upper lobe sign, where we see honeycombing and cysts in the non-dependent upper lobes, much more exuberant than what you're seeing in the lower lobes, is again a very specific sign that points us towards connective tissue disease and commonly seen with rheumatoid arthritis and scleroderma. Island-like fibrosis is when we see these wedge-shaped areas pointing towards the hilum with the rest of the lung being normal. So this typically suggests the vasculopathy, and then because of an incident, there's been fibrosis and honeycombing, and this is seen with SLE and scleroderma. And when we have island-like fibrosis in these four corners, then we call it the four-corner sign. So anterosuperior and posterior-superior, you can best appreciate this in the sagittal images. The other sign after the anterior upper lobe sign that in day-to-day practice helps us look for connective tissue disease is the straight edge sign. And this again tells us that we need to look at the sagittal and coronal images in virtually all patients who come with connective fibrosing ILDs. And so typically, when we're reading scans, we're looking at the axial, coronal, sagittal together on the workstation. And when you see the straight edge here, then it tells us that we're likely dealing with connective tissue disease ILD. So the transition between normal and abnormal is very sharp. So here's a CTD ILD, and here is IPF, where the transitioning is not sharp, where the shape is all over. There's no straight edge, there's an undulating edge between normal and abnormal. And then when we talk of connective tissue disease ILD, we come to NSIP, which again can be a confounder, can look like a probable UIP pattern in the younger age group. And you can see here that there's temporal and spatial homogeneity. So at each section, the age of the lesions looks to be the same. You have reticular opacities, you have traction bronchiectasis, but there's this hint of subpleural sparing. So you can see that lucent line between the reticular opacities and the pleura, and that's your classic NSIP or non-specific interstitial pneumonia pattern. It can be both fibrosing and non-fibrosing. More importantly, it may precede full-blown connective tissue disease by a few years. And even more importantly, idiopathic NSIP is extremely rare. And that's how we can differentiate your UIP IPF, where you have subpleural involvement, from NSIP, where there is subpleural sparing, which is often better appreciated on the sagittal images. No sparing, sparing. Now, all NSIPs don't have sparing, but when you see it, it allows you to make that diagnosis, and also therefore gives you the confidence that there is likely underlying connective tissue disease. Then we have interstitial lung abnormality, a term that is becoming more and more used simply because as we scan more and more people for multiple indications, we find, especially in older people, incidental interstitial abnormalities, right? And the important thing to understand when we use this terminology, that it is in individuals in whom ILD is not suspected. And it's important because in some patients, the ILAs can be precursors of IPF or be early IPF, but the patient is not symptomatic. So you have non-subpleural here, subpleural non-fibrotic, see these subtle reticular opacities, and subpleural fibrotic, where you have traction bronchiectasis as well. But remember that the term ILA is to be used when we see these interstitial lesions in asymptomatic people, when these are incidentally detected because they were scanned for some other reason. So it's important to know what is not ILA. So in smokers, when we see these ill-defined centrilobular opacities, that's respiratory bronchiolitis. If in the prone images, these opacities disappear, then these are dependent densities. If you see bilateral pleural effusions with ground glass and septal thickening, that's interstitial edema. When we see these ill-defined centrilobular opacities only in the dependent segments, then these are due to aspiration and periosteophyte lung changes or fibrosis. These are not significant. They're always asymptomatic, and this is not an ILA or interstitial lung abnormality. So the third bucket consists of patients who have ILA, consists of unusual presentations of fibrosing ILDs where we shrug our shoulders and say, we do not know what the etiology is. And in those situations, you would probably need to biopsy these patients, or more importantly, at least discuss this in a multidisciplinary setting and then come to a conclusion as to what is the next path to be taken. One curiosity is the reverse UIP IPF, where we see reticular opacity, subpleural, but apical predominance and traction bronchiectasis. And on the coronal and sagittal, you can clearly see that the bases are significantly spared. And this is an apical disease with a little shrinkage of the upper lobes and the bilateral pneumothoraces. This is very, very classic of pleuroparenchymal fibroelastosis or PPFE, and it kind of looks like a reverse UIP IPF. Lastly, we look at combined pulmonary fibrosis and emphysema or CPFE, which occurs typically in smokers. We see a combination of emphysema. Here we're seeing advanced destructive emphysema with exuberant honeycombing and cystic change. So this is airway expansion with fibrosis, which is a subtype of smoking-related interstitial fibrosis. Looks like UIP, and if you were to use the term UIP, that would be fine as well. But the combination of interstitial fibrosis or a fibrosing ILD in the basal segments and emphysema in the upper lobes is called CPFE. It behaves a little differently as compared to just an IPF or just emphysema, and needs to be managed accordingly. So the aim today was to look at all of these things. I've already discussed the protocol in the earlier lectures as well, where we need high quality scans with volume supine 1 millimeter inspiratory, expiratory, and volume prone 1 millimeter inspiratory scans to begin with. And it's only when we have those high quality scans, that we're able to, make a good diagnosis. For those of you who might want to read more or listen more or hear me more, sorry, I've done a bunch of these lectures last quarter, and they're all available for free. I do post cases very frequently on my WhatsApp channel and other social media channels, but you can subscribe to this. That's my new book, which is available on Amazon, and that's the CTILD book, which is also available on Amazon. Thank you so much for listening to me, and have a great meeting. Have a great week.
Thank you, Professor Jhankaria. It was lucid to listen, Dr. Jhankaria, who has described so nicely the UIP by definition, probable UIP CTs, indeterminate for UIP CTs, and alternative diagnosis. He was very, very clear in his presentation what IPF means. As we know as clinicians, that honeycombing, bibasilar crackles, without any other confusion in the CT, directly it is UIP. You don't have to worry about anything. So ILD, IPF, UIP, it's a clear entity. Rest of the things are probable, indeterminate, and alternate. And UIP like presentations like sclerosing, asbestosis, Pudlock syndrome, rheumatoid arthritis, they look like, but here the history is very, very important. We are going to come up with all lucid discussion in the coming time. Now we switch on to Yuvarajan. I have introduced him already to come and speak about the IPF, UIP, which is the discussion for today. And I must honestly thank Amita. Why? Because of her, I could read 2012, 2018, 2022 guidelines to clarify how the IPF has progressed. And I am here to discuss with you. So I am also ready what you are ready. Thank you. Over to you, Rajan.
Yes, sir. Yes, sir. Thanks for the introduction, and of course, thanks for the opportunity from ICS. And I thank the ICS office bases, especially Dr. Amita Nene, Madam, and Dr. Rakesh Chavala, sir, for introducing me to this interesting webinar. I hope you can see my slide.
Yes, sir, it's visible.
Yeah. See, the topic that is I've been asked to discuss is it's an area that I'm so interested and want to explore more. That's an IPF. As we have discussed that it is idiopathic pulmonary fibrosis. As the name indicates, lung getting fibrosed without any obvious cause. After ruling out everything with proper history taking and proper investigations, then you can make a diagnosis IPF. We have been hearing Dr. Jankaria's the recorded lecture that UIP and IPF is totally, like UIP is a the pattern that what you see in CT, but IPF is a clinical diagnosis. Like you can't tell all the UIP pattern as IPF. Okay, so that's the thing that we need to understand. And as you all know that IPF is an architectural chronic fibrosing interstitial lung disease, which is characterized by a typical HRCT pattern that we have already discussed in the last lecture and typical histopathological pattern of usual interstitial pneumonia. The main thing is that you need to differentiate the fibrosing ILD. Why? Because the differentiating IPF from other close mimickers, other conditions within the spectrum of fibrotic ILD has some management implications. Because if you catch UIP with underlying CTD, which has some systemic manifestations, and it has a possible management protocols, like we have n number of immunomodulators which can do magic on these patients. So that's why catching hold of this patient is very, very important, because because IPF is one of the terrible disease, a bad disease, and you should not miss that. And we can only arrest the progression. For that only, we need to definitely differentiate this form of fibrotic ILD from other things. The diagnosis of IPF can't be made with a single parameter like what we discussed with radiology imaging, or sometimes even with biopsy also we may have a difficulty. So that's why we all sit together with a multidisciplinary team in some cases where they have a confusion is there, with radiologists, pathologists, rheumatologists of course, and pulmonologists who are experienced in managing the ILD, for discussing these type of cases to arrive at a diagnosis. You see the incidence and prevalence of interstitial lung disease worldwide and where this IPF stands. Actually, the prevalence data, whatever we are seeing in the literature, obviously it is underreported, because, most of the times IPF, as like other diseases, we don't have a specific clinical symptoms to tell that this is IPF or this is a fibrosing ILD. Most of the lung disease present with a chronic cough. Especially in ILD, you'll get a dry hacking cough and the breathlessness, which is a symptom which will be seen in other conditions also. That's why many patients will come to us very late, and that too, half of the lung might have been fibrosed. In that situation, you will see the patients. So whatever prevalence I could see in the data is somewhere between 7 to 1,650 cases per 1 lakh population. And for IPF, when you see the scleroderma, that incidence varies. If you see the data from India, that is a registry of ILD from Dr. Duria publication, if you see that sarcoidosis forms a major chunk of the cases, almost 37%, followed by CTD ILD, and followed by idiopathic pulmonary fibrosis. As I already discussed that, any condition, if you want to diagnose, you need to take proper history from the patient. You need to understand the symptomatology. You need to record the history properly so that half of the diagnosis will be over. And after that, you have to see other investigation to clinch or to join with your clinical acumen, and then you can come to a final diagnosis. See, as I already discussed that these patients will have a chronic dry cough, and the cough will be very hacking nature. So they will have a continuous cough which disturbs their sleep and which disturbs their normal activity. So it starts with a cough, sorry, and progressively, if you are not treating this patient, they may go with breathlessness. And what is more typical in that, when you do examination, what is the important sign you should not miss is that almost 50% of the cases will have a digital clubbing. That you should note. And most importantly, when you auscultate this case, when you do a auscultation, you get a classical end inspiratory fine velcro capitations that are the sign of extensive fibrosis in the lung. That is very typical of most of the times in the UIP pattern, that usually idiopathic pulmonary fibrosis. And once you see all these things, then you have to go for X-ray. So as we do for all the chronic lung disease, we will see the basic X-ray. In the X-ray, you will see the typical distribution. You will see the basal zones are, that is lower zones are more commonly involved, and you will have a decreased lung volume and the signs of fibrosis. You will see in the X-ray like subpleural reticular opacity that may increase from apex to base. And we have discussed that the pattern, what you see in HRCT is that very typical. You will have a gradient. You will have apico-basal gradient will be there. The lesions are more in the bases when compared to apex. The lesion increases gradually from the apex to the base. And you have all the signs of fibrosis. So as a name indicate, all the signs of fibrosis will be there. The fibrosis signs will be, it starts with a minimal or patchy ground glass, because ground glass also is a sign of fine intralobular fibrosis you may get, but the ground glass should not be extensive in CT. That is another important feature that you should see. You will have a ground glass only around the area of fibrosis, only around the area of signs of fibrosis. Then you can take that. That is one of the classical picture of UIP pattern. Next to that, other signs of fibrosis that you will see the reticulations because of interlobular, intralobular fibrosis. And once the fibrosis extends, it also involves a distal airway. That is a terminal bronchioles and terminal airways that can present with a traction bronchiectasis or bronchiolectasis. And then final form, after any end fibrosis, you will see a honeycombing. That's one of the classical feature you will see in CT. Out of all the CT signs, which is the most important clinical sign to CT sign to tell you that the patient is having UIP is that presence of honeycombing. You should not forget, presence of honeycombing almost into the diagnosis of UIP pattern. If you are not seeing honeycombing, next to that, you look for a traction bronchiectasis or bronchiolectasis. That is the next probability. And finally, reticulation. So these are the things that you need to focus on the CT. So this is what I was discussing. You can see the typical, the gradient of distribution of lesion. You see the apex, there are no lesions, and you can see the lesions progressively increases once you go to the base. And here you see the areas of low attenuation, high attenuation. What is low attenuation is nothing but dark area. High attenuation is nothing but the white areas. So high attenuation is in the form of lines, multiple lines are there. These are nothing but a reticulation, what we are discussing. And then these reticulations are signs of fibrosis that you expect in a patient with idiopathic pulmonary fibrosis. And you see the, the cystic appearance in the subpleural area that we have been hearing Dr. Jankaria's lecture. These are the classical subpleural honeycombing, which are typically seen in a patient with a IPF or UIP pattern. So this is an update from ATS ERS guidelines. What are the different patterns you may expect? You may expect in idiopathic pulmonary fibrosis. Here we have already discussed the UIP classical pattern. It helps us to confidently diagnose almost 90% of the cases. If you see a CT picture like this, you can fix that this CT is because of is due to background of idiopathic pulmonary fibrosis. The first with the distribution, as everyone is discussing, it only involves the edges of lung. It only involves the base of lung. So basically, involvement of subpleural and basal predominant areas. The lesions are heterogeneous. You see that what is heterogeneous? As you see in a chickenpox lesions, you see vesicles, you see papules, you see pustules, you will see all type of lesions in a single area. Same way, the heterogeneous pattern is that some area will be normal, some area will be having a minimal fibrosis, some area will be having extensive fibrosis. All these things seen as a normal lung or minimal fibrosis will be seen as a fibrotic area reticulations, extensive fibrosis will be seen as a honeycombing. All these signs, if you see in a CT, you can confidently diagnose that this patient is UIP. And previous guidelines, they have been stressing on the point that it is a symmetrical distribution. But of late, we don't see the textbook description. Whatever you see in UIP, you may see asymmetrical pattern of distribution of lesions in the CT. That also points to a UIP pattern. So CT feature, once again I'm telling, number one sign you see in a CT is honeycombing. If you see honeycombing, your bell should ring that we are dealing with UIP. And number two sign is traction bronchiectasis, bronchiolectasis. Number three is reticulation. Number four is GGO. Note this point, it is only a patchy GGO or mild GGO. This GGO is a sign of fine area of fibrosis you see in the lobules that you are seeing. And most important point is these patients also have pulmonary ossification. That's why of late in CT, HRCT, I am also asking the bone window or a mediastinal cut also to look for the edges of lung. You can see the ledge of lung will be calcified because of the chronic, healing area, because of the chronic involvement at the edges of lung. You will have a dendritic pattern of calcification. That is one of the additional signs you may see in some cases. That I think I'm very happy to see that guidelines, they have included this also in one of the pattern that you see in UIP. Next to that UIP classical pattern, you have to see the probable UIP pattern. If you see a probable UIP pattern, then you can confidently diagnose IPF by 70 to 89%. In that case also, you can almost fix the patient as IPF patient only. So here also you can see the same distribution. You have a subpleural and basal predominant disease. Definitely you have heterogeneous involvement. You have a normal area interspersed with the area of fibrosis, minimal fibrosis, extensive fibrosis. All these things will be a mixer you see in a same patient. The thing is that what is the differentiating point between classical UIP pattern and a probable UIP pattern is that you don't see a honeycombing here. You will see everything there. You will see the pattern of distribution, you see the pattern of fibrosis, but you don't see the honeycombing. Once you are not seeing the honeycombing, definitely your mind should think that we are dealing with some other disease also. But you have other features of there. That's why we are keeping this terminology as probable UIP pattern. I'll tell you one more time. In probable UIP, you are not seeing honeycombing. You will see the traction bronchitis, bronchitis. That is one of the sign of fibrosis you will see in these patients. Next to that, you see the indeterminate pattern. This is, you can diagnose them with a low confidence, provisionally low confidence. With this CT, you can't, confirm that the patient have IPF, but if you have a good MDD, but this type of cases, you go for a biopsy because we need to see the pathology to tell you that whether we are dealing with, IPF or not. That's why UIP or not. So that's why we need to, you need to discuss with the pathologist to see whether this is really UAP or not. So here also, you don't see the classical, the basal distribution. You have a diffuse distribution of disease without a subpleural predominance. And then CT feature of the fibrosis that do not suggest any other specific etiology. All these things are intermediate pattern. This intermediate pattern for UAP is this group of cases you need to catch hold, and this group of patient only we have to target for biopsy. The CT findings which suggest for alternate diagnosis. All other findings which is not with that. See, that is suggestive of alternate diagnosis. For example, if the lung edge is not involved, subpleural area is not involved, any patient who have the involvement of peribronchoalveolar area, perilymphatic distribution, any patients who have a distribution of lesion is reverse of UAP, that is more in the upper and mid zones. Any patient who are not having a subpleural involvement, but there is a subpleural sparing. All these things are points towards a diagnosis against UAP. That means other than UAP, you have to think of. Other thing is that seeing a large bizarre cyst, seeing the multiple cyst, seeing a evidence for small airway disease, that's a mosaic attenuation. What is mosaic attenuation? Nothing but it's like a mosaic, tiles. You will see a altered attenuation. You see a dark and white areas that will intermix, that you can see in that, and presence of nodules and consolidation. It is totally against the diagnosis of UIP. This is what I was discussing. These are the patterns that you should not see. You see that these are the areas of mosaic attenuation. These are if you see this type of dark white areas, that is a sign of mosaic attenuation, which involves either the terminal airways are involved, small airway disease, or it also involves in the extensive vascular disease also, either vessels or airways. And most commonly you will see in an airway disease, especially in a patient with the HP and all, you will get it. So this suggests an alternative diagnosis. And this is what I was discussing. You see the classical subpleural involvement, edges are lung involved, and then you can see the traction bronchiectasis, and then you can typically over the posterior area, that is 6 o'clock position, you get a grouped up cysts that are called honeycombing, and you are seeing the traction bronchiectasis and bronchiectasis. Here, sometimes honeycomb won't follow the classical textbook description. In case of extensive fibrosis, you have a 2-3 cysts joined together to form a multiple bizarre cyst also. That also you can see in a honeycombing. Here, what is more special is that you can see the areas of ground glass. You see the areas of ground glass, which is more extraordinary. It is more than what we expect in a UIP. That's why this is not only UIP, this is some other thing along with UIP. These are the cases that are recorded from the acute exacerbation of IPF, where you have a new onset of ground glass opacity with the background of fibrosis, whatever I discussed. Here, once again, you see that here in this CT, nowhere you see the edges of lung is fibrosed. You see the slate gray appearance. You see the classical reticulations. You see the airways are tracked up to the edge of the lung. These are the traction bronchitis and bronchiectasis, but you are not seeing honeycombing. You are not seeing cyst in that area, any of the areas, edges of the lung. That's why these type of cases, if you are not seeing the cyst or honeycombing, but it fits with the classical distribution of lesion and other things, if you are fitting, you can fix that as probable UIP pattern. And here, you see, these are the typical honeycombing I was describing. You see that the evenly sized shad walls, cysts are there in the lung edges. And here you see the piling up, like you see the necklace pattern. You see the piling up of cysts by layer by layer. Very, very classical of patients with the UIP. And you see here also you can see air filled space in the lung, but you see that this is more distributed in the upper zones, not in the bases, and these are large enough, and the wall is very thin. These are not shared walls. This is actually a paraseptal emphysema, which is one of the close mimicker that you need to see that. Sometimes you face a difficulty. The same patient will have a COPD. The same patient will have IPF also. Very much problematic area. You need to read the CT properly. And one more entity called CPFE. In upper lobes and upper zones, you will have an emphysema. In the lower lobes, you have a finding suggestive of UIP. Yeah, this is what I'm just telling that not all the honeycombs what you are seeing that clinches to that clinches to only IPF, because UIP pattern is a common pattern you may see in any condition which cause extensive fibrosis. Out of that, one condition is IPF. Here you see that the same honeycomb is there, but instead of moth eating the bases or the posterior part, you see that this almost involves the anterior part. This is the anterior upper lobe sign. That's what Sarah has discussed. This is one of the important sign you see in CTD-ILD. Mostly this type of sign you will see in RA-ILD and scleroderma ILD. And here also you could see the honeycombing is there, but you see that this whole of the cut is replaced with multiple cells. This we call it as exuberant honeycombing. That means that honeycomb is extensive in such a way that more amount of fibrosis is there that we don't usually expect in a patient with IPF. This exuberant honeycombing may be there in late stage of IPF, but actually if you see a normal lung at one part, but you see the almost 70% of lobe is involved, completely replaced by cyst, then you should think of CTD-ILD. That's one of the important signs in CTD-ILD you should not miss. Then comes, acidity patterns we have described. We have just seen what is IPF and what is the UIP pattern, all these things. Then we have to just combine all these things to come to a conclusion that whether it is IPF or not. What is the role of bronchoscopy? Here, is there any role for BAL cellular analysis? Definitely, because already it is a fibrosed lung. Nothing you could get in BAL. You may get a neutrophilic predominance, but it won't help you for the diagnosis. I don't think the BAL should not be, investigation of choice when all the patient IPF. But unless otherwise you think other diagnosis also is there along with the patient. Suppose I got one patient of IPF along with the fever, the cavity. If the patient is the thing, you think of other infectious etiology like tuberculosis or other things. If you want to rule out, then you can go for a BAL analysis. Otherwise, you should not go for BAL. Moreover, these patients are hypoxemic, pushing the BAL and taking the BAL with conventional sampling and all. Post procedure, you will go for hypoxemia unnecessarily. If a procedure is not yielding the diagnosis, then why we should unnecessarily do the procedure? That's why BAL is not at all indicated in a patient with IPF majority of case. What is the role of transbronchial biopsy? Obviously, those patients who got a confident diagnosis in UIP, either having honeycombing or traction bronchitis bronchiolitis with a typical distribution, with these patients, we don't have to do anything. With a high pretest probability, clinical probability in a classical patient with a distribution of lesion, whatever I've described, that you can label them these patients as IPF. But those patients who have intermittent pattern or alternative patterns or cyst, cavity, consolidation, or the intermittent pattern, only reticulations are there, no honeycombing, no traction bronchitis, these patients you should catch hold and you do a biopsy. The next question is that how you are going to do biopsy. Here I told you the heterogeneous pattern that you need to describe either in a CT or biopsy. The heterogeneous pattern means that you should catch hold of the normal lung, you should catch hold of the fibrosed lung with varying degree of fibrosis. For that, you need to have a large sample. As you all know that whatever sample we take from the transbronchial biopsy is very small and it is not sufficient for the patient with conventional methods for the diagnosis of IPF, because pathologists may not be happy to confidently tell that this is a UIP pattern. So for that, there is a revolution is that we have got a good cryoprobe. We have a smaller cryoprobes are there. We can diagnose this patient easily with a transbronchial biopsy. Otherwise, conventional biopsy, I think you should not attempt, because conventional biopsy, it can reach up to the level of bronchioles. You can sample the area very close to the bronchioles only, and the areas which are involving in the terminal air spaces close to the bronchioles, bronchiolitis related disease, for example, sarcoidosis or other granulomatous HP and all, you can go for a biopsy. Transbronchial biopsy by conventional, not with the IPF. Then what is the role of serological test? For telling this patient has idiopathic pulmonary fibrosis, you need to have extensive investigation, either by history and investigation. For that, underlying CTD has to be ruled out, because CTD is also one of the condition which can cause extensive fibrosis in the lung, which can cause UIP-like pattern. That's why serological test is mandatory. And next question is whether without symptom also we can do. Yes, without symptom, because CTD-ILD has a clear protocol for management. Definitely, we can arrest the progression in most of the patients with a good immunomodulator therapy. Moreover, they have other systems also involved. We are not authorized to lose that patient. That's why we do a serological testing. At least the basic ANA test, that is IF method, can be done for these patients. And next comes the physiological test. How far? Because for the diagnosis and the prognosis and follow up of the patient, how the patient is improving, because we can't reverse the fibrosis. We can't do a follow up with the CT and all as we do with other infectious etiologies. We do all the physiological tests. We do all the functional tests like 6-minute walk test and all to that. Obviously, we see a restrictive pattern and you need to document the FEC. And every time when you see the patient and you have the clear protocol that I'm going to discuss in a further slides, when you do a repeat PFT, repeat spirometry and all to document the fall in FEC, because these IPF patients are so dangerous, they are totally unreliable. Their FEC will drastically reduce in a matter of time. You need to catch out of the patient and need to follow up the patient dramatically to avoid all these complications. And there are certain markers are there. Whether these markers are helpful or not, no, because these are more of theoretical and in the study wise is there. Even I have given a thesis last year also for one of my PG on the serum and ball markers. Actually, we did a KL6 in group of patients and categorized the patient. This is helpful for both diagnosis and prognosis. We are a long way behind that to have a biomarkers. I think in future, like if you have good studies, and then we can include that in that. And lung biopsy, how do you do that? There are two options. Either you got a big chunk, either the cryo biopsy, or you can go ahead with a surgical lung biopsy. The problem with surgical biopsy is that we can't do for moribund patient. Comorbidity is very difficult to get a clearance. Not only that, these patients actually has to stay, and the cost is also matters a lot. We have a good option like transbronchial cryobiopsy, which is almost gives a good yield to help the pathologist to arrive at a diagnosis of UIP. And in transbronchial cryobiopsy, you need to catch hold of multiple lobular biopsy. You should not take a biopsy with a single segment, because you are authorized to lose the diagnosis, because you need to catch the multiple areas. You need to take from the same side with the different lobular segments, and then you can get the sample. What is the classical pattern you see in a UIP? The same thing. You see all the signs of extensive fibrosis. The first thing is that subpleural normal should be there. You should give a tissue where the pathologist should see in the macroscopic area, the subpleural area should be involved. And then you should see a heterogeneous pattern of distribution of lesion. You see the heterogeneous already described. One area, you see the normal lung. One area, you'll see a mild fibrosis. One area, extensive fibrosis. One area, you get a fused out lung. That is a honeycombing will be there. That's a very classical distribution you see in UIP pattern. And this is what we have described. These are the different histological patterns you see. A classical UIP pattern have a dense fibrosis, occipital distortion with honeycombing, typically distributed in the subpleural and paraseptal areas. The patchy involvement of lung parenchymal fibrosis is very classical. You don't see a complete fibrosis. You have focal fibrosis, areas of fibrosis intermixed with a normal lung. And then very important, you will see the fibroblastic foci. Presence of fibroblastic foci gives the pathologist clue that we are dealing with UIP. But you see the giant cells, but if you see granulomas, other abnormal things in a biopsy, that clinches the diagnosis against a UIP pattern. This is what, after combining both the things, like you combine the HRCT pattern, you combine the biopsy pattern. If you see HRCT pattern of UIP, and the pathology also telling that is UIP, confidently you can tell that after ruling out everything, you can tell that we are dealing with IPF. If you see HRCT pattern of probable UIP without a honeycombing, but you see UIP pattern in a pathology, because when you do, once you do a biopsy, classically if you are telling UIP, that is the ultimate, that's a gold standard. You don't have to do anything. So the question arises when they give a probable UIP. Even in histopathology, after doing a proper biopsy also, they give a terminology of probable UIP. That's what we have described. For this group of patients also, most of the times when you discuss, you can label this patient as IPF. The catch-hold here is that those patients who have an indeterminate pathology, that is in the pathology also after doing biopsy, if they are not very confident about the subpleural element, if the areas around the terminal area is involved, not the subpleural area, and if there is not a heterogeneity of lesions, what you see classically in a UIP, then you have to think there's intermediate for UIP. So this is a big headache. If there is an intermediate pattern in HRCT, we rely on biopsy. If after biopsy also if we get intermediate pattern, then we have to rely on ourselves only. Human brain have to think that you have to sit together, discuss with other specialists, discuss with other consultants, and then come to a conclusion. That's what MDD plays a major role. After doing biopsy also, if you are not getting a diagnosis, then you have to place this case with the MDD. By seeing all the other clinical probabilities, by ruling out other things, we can fix this as UIP or IPF or non-IPF. Once again, the protocol, you see that suspected patient having IPF, you rule out all the potential cause and associated conditions. If everything is not there, then go ahead with a HRCT, which is the classical, the investigation that will tell you the diagnosis very clearly. Most of the things, like if you see a classical distribution of lesions, whatever I described, you can confidently diagnose that this patient is a UIP pattern. So you see that HRCT telling a UIP or probable UIP, after ruling out everything, then you can just tell that there is a idiopathic pulmonary fibrosis. But if the HRCT is telling indeterminate pattern, that means that no traction bronchiectasis, no bronchiectasis, no areas of honeycombing, that there comes a problem. Only areas of subpleural reticulations are there. There comes a problem. That is intermittent pattern. So then you have to put this case on MDD. With MDD, then what we have to do? We have to decide on what mode of biopsy you have to take. So you have to do either a transbronchial lung cryobiopsy or a surgical lung biopsy. Most of the times in good centers, we can catch hold of the disease very good with transbronchial lung cryobiopsy. After getting transbronchial lung biopsy also, once again, you have to ask for an MDD, then you can just fix that whether the patient comes under IPF or non-IPF. So there are some situations where you get indeterminate pattern and some HRCT may be indeterminate. After biopsy also you will not get a conclusion. There comes the role of MDD. So in that situation, what you have to do? You have to see the picture as whole. If there comes a good clinical history, you have to take the history properly. And there are some pre-test likelihood things that you have to think and you have to fix and to arrive at a diagnosis. Here you see that the likely possibility of clinical likelihood is very high when the patient is male, when the patient is more than 60 years, when the patient is a smoker. Very, very important. Smoking is considered one of the important risk factors for developing IPF. And clinical sign, getting a Velcro crackers is very, very good sign that you should not miss. And then clubbing, if it is present, more than 55% of cases you will get classical clubbing. Exposure to antigens and other antigen tests, if you would have done for this case, if it is absent, no other autoimmune features, clinical features or serological features, no different diagnosis you are keeping in mind. And family aggregation, some patients, if it is yes, then you have to think of this IPF, lung function, restrictive pathology, and chronic onset, typical chronic onset. These are the signs. If it is there, it is more likely that you are seeing an IPF patient. Other things like if you are seeing a female patient having an age less than 50 years, non-smoker, absence of typical crackles, but you have got occasional fine crackles, or getting a squeaks is totally against, because squeaks is not the common clinical finding, or wheeze is not a common clinical sign you expect in a patient IPF. If squeaks are there, that shows that the patient is having extensive bronchial ear disease. That disease is very common in HP. In case of fibrotic HP, you get a squeaks, that you should not miss. And then that likelihood ratio for getting IPF is less when compared to the other things. Clubbing is classically absent. You see other autoimmune features, both clinical and serological, and the onset is either acute or subacute, not a chronic one classically. And other things like if you have parameters, if you have good workup, if you follow up the case, suppose if the patient is not willing for a biopsy, if you follow up the case, if the patient is clinically stable for long years, definitely you are doing some mistake. That is not IPF case, that's some other thing. Because typically IPF is a progressive disease. It's a very bad disease pattern. Most of the patients will succumb or progress within a matter of years, that within 5 years. And then if the patient responds to steroid, if somebody has wrongly started steroids, but the patient shows clinical response, definitely that is not a old fused out lesion. There is ongoing inflammation is there. You are missing out something that you need to catch up. And if you see a ball, if the ball shows lymphocytes more than 30%, that you will never get in IPF, except in situation where you will have mixed pathology. If you have a TB and all these things, you will get a lymphocyte predominance. Even that also you will have a mixed pathology. You will have a neutrophil predominance only, not a lymphocyte predominance. And if you have a facility, there is one more thing called genomic molecular classifier. This is one of the machine reading. It has a good specificity and less sensitivity. Even the guidelines are telling that it is very good for picking up the UIP pattern, even with small samples also. But we need more studies for this, and even the recommendations are not guiding us to use this molecular classifier. And these are the different pattern. Like if you see a patient with typical 68-year male. Suppose this patient is 20 pack years is there, Velcro crackles, builder, no other exposure, chronic onset, restrictive physiology, having a pattern like this, you see that you see here asymmetrical distribution. You see that right side you see a lesion, subpleural area involved, and left side you see a very minimal lesions are there, and subpleural area is involved, but you see more of minimal GGOs along with reticulations with minimal bronchiectasis, and you see there is no area of honeycombing. That's why it is labeled as probable UIP. Even though it is labeled as probable UIP, but the pre-test clinical probability having everything, more than 60 years, having smoking history, everything is there. So you can confidently place this patient as IPF patient without going for a biopsy. Here you see that the same thing, but it is a female patient, smoker. It's a data from foreign, ex-smoker. Velcro crackles are there, but the patient is having Raynaud's phenomenon, but other things are there, and restrictive physiology, chronic onset. Here also not much of honeycombing. You will have label this CTS probable UIP pattern. But these cases actually what happened, like he's a female patient, all these things are there. The patient, we would based on the MDD discussion, you can place this patient for a biopsy. With a biopsy, if the biopsy also shows a probable UIP pattern, then you can confidently label this patient as a IPF. So next is the natural history of disease, how far the disease is there, because many times people will ask like, whether, how do you treat? Patients are stable, sir. Accidentally a cough is there. We did CT, subpleural fibrous honeycombing is there, whether to give a treatment or not. See, I'll tell you, this is actually, IPF is a bad disease. You can get, a drastic, reduction in the FEC and all. You have a progression of fibrosis in a matter of time will be there in a subsequent days. So you are not authorized to lose these type of cases. That's why all these patients, you explain the patient, even though you do not have symptoms, you should start a treatment not to reverse the fibrosis, at least to harass the progression of disease. It is unpredictable disease. Most of the patients will have a slow, gradual progression. Some patients will have accelerated decline, but we need to have a lot of phenotypic studies to find out this case. The mean survival time, this is older, this thing is 2 to 3 years, but we have a good number of antifibrotics, and many people are using that. But the problem is that post-COVID, the antifibrotics have been misused for other, other fibrotic ILDs also, but that should not be done. And next is acute examination of IPF. If you see, increased symptoms like in worsening of dyspnea within a matter of 3 days, appearance of new ground glass consolidation. That's what I discussed in the previous slides with HRCT. If you rule out other infectious causes and other causes which leads to ground glass like heart failure and embolism, then we can fix this as acute exacerbation. The thing I'm telling you, any chronic lung disease, the best thing is to prevent the patient to come to hospital, prevent the exacerbation. That is very, very important. That's why we play more, we give more importance to vaccination and all, because preventing this patient to come to hospital exacerbation is one of the major thing to prevent the progression of the disease. That is a progression of the accelerator fall that you get in a lung function test. Next comes the treatment. How do you treat this case? Basically, this is a fibrotic lung disease. So obviously, we don't find the cause for fibrosis. The option is we have antifibrotic therapy. We have two well-documented antifibrotic agents are there, perphenol and nintedanib. And I think no one needs any introduction for this, because many people are using it. And other thing is symptomatic relief. Most of the patient after starting this also, even the trials also telling that you don't get a rapid symptomatic relief. These patients are having will have a terrible cough, and hacking cough will be there. That will be only partially checked upon with this antifibrotics. You may have a continuous cough. And other things like vaccination, treatment of comorbidities. Obviously, hypoxemic patient, you need to give oxygen for this patient to prevent other drastic deleterious effects of hypoxemia in this group of patients. Rehabilitation, like you do in a chronic obstructive pulmonary disease, you do rehabilitation. You need to teach them how to cope up with the breathlessness. You need to teach them how to take care of their cough and all these things. And those patients who are bedridden, you need to decide on the hospice care. This is what update what we have for the treatment of UIP, nintedanib, pirfenidone. That's what we are going to discuss. And other pharmacologic, non-pharmacologic agents like therapies like oxygen supplementation, rehabilitation, and all. And you need to check on the comorbidities. Hypertension, pulmonary hypertension is one of the bad things that you get in IPF. Most of the lung disease will have a mild to moderate pulmonary hypertension. If you get a severe PHT, try to rule out other concomitant cause for severe PHT, not related to only IPF. But if you get it, it's a terrible combo. You will the patient will collapse in a matter of time. You need to check all these things. And we don't have a good therapies for PH also, except for a few drugs that I'm going to tell in subsequent slides. And how do you monitor this test? Basically, you can't do X-ray or CT. You don't see that frequently. You just do a functional test and physiological test, a PFT or 6-minute walk test every 4 to 6 months or sooner if it is clinically indicated. And at least you do an annual HRCT if there is a progression or worsening, or you have to rule out lung cancer, because fibrosis itself is a risk factor for lung cancer. Most of the patients will have a history of smoking also. Obviously, we need to catch hold of lung nodules early. That's why CT is also very important. Acute exacerbation also, we need to take care with the corticosteroids. I'm telling you, corticosteroids may not work most of the times with acute exacerbation, because 50% of the patients succumb with even corticosteroids. If a corticosteroid works dramatically, then that is not a true exacerbation. True exacerbation, definitely you can't save the patient most of the times. A lot of trials are going on with cyclophosphamide and all, but nothing will work for the patient with the exacerbation. And finally, ultimate resort, remove that fibrosed lung, change with a new lung with the lung transplantation. These are the obvious things that we are going to discuss in a subsequent panel discussion. A little bit about whether GERD to be treated or not, and there's no need to unnecessarily put this patient on additional drugs, because already we put this patient on pirfenidone. And hypoxemia, definitely we need to give oxygen for this patient. And one new addition is that hypoxemic lung disease, group 3, there is no obvious treatment for pulmonary hypertension in group of patients, but they have given a good try for inhaled treprostinil, which has improved exercise tolerance and NT-proBNP levels, and is approved as a first number one drug for the ILD with the WHO classification of group 3. Because previously we were using sildenafil and all, but sildenafil should not be used, because sildenafil, even though we tell that it's a vasodilator, but most of the studies actually, are against sildenafil because we don't know. Most of the times it's because of hypoxemic pulmonary vasoconstriction. If you do give sildenafil, what will happen? It will cause a worsening of VQ mismatch. It can further worsen the oxygenation, and it because like it is a good evil. Hypoxemic pulmonary vasoconstriction is a good evil, and we should have a careful approach for this group of patients, because if you touch it, what will happen? You will have a deleterious effect. So that's why you can't use sildenafil and other drugs. And rehabilitation, lung care and all, we're going to discuss, and palliative care. Ultimately, lung transplant is the last resort you have to do for these cases. A prolonged survival, improvement of symptoms in the PF-ILD, and you have a survival rate also is there pretty good with transplantation. Those patients who are at the risk of progression with your clinical acumen, definitely you need to send this patient to the transplant area to get the lungs changed. And the palliative care, the dribbling symptoms of dyspnea and cough is very challenging. We have a lot of other drugs are there to suppress the cough and all. And you need to explain the relatives regarding the regular care and explain regarding the vaccination. And that's the thing. So don't, leave the case, catch hold of this patient and then treat it early, so that, we can manage all these patients with a, good treatment. Thanks once again. We'll meet you in panel discussion.
Thank you, Yuva,
Thank you,
for
sir.
such a nice and lucid presentation and describing IPF, non-IPF, IPF exacerbation, recent modalities, treatment, what to be done, what not to be done, adding about pulmonary hypertension in IPF. I think the whole talk has been lucid with radiological patterns, and I am very happy to listen you as a very good orator, and I am sure all of us have enjoyed. Being a moderator, I will definitely like, this is one of the most common pulmonary fibrosis. Though it is a specific cause is unknown, it affects majority of, say, 50,000 people in US every year, and is marked by excessive inflammation and lung scarring, which is very difficult for patients to breathe. The saying is the people living with pulmonary fibrosis face deteriorating lung functions, worsening respiratory symptoms, reduced quality of life, which can ultimately lead to respiratory failure and death. Now, since a disease which disturbs the patient mentally, physically, family involved, and I'm sure Alpa Dalal is having an holistic approach, is one of the panelists with us. You are going to enjoy her participation into this. Leave aside the therapies. We know we cannot finish IPF. We can reduce the progression of IPF properly. The drug is used for UIP, and it helps you to stop the declining of FVC in a patient. But more so, when the patient is suffering, the family is suffering, everybody is getting onto Google, seeing the lifespan of IPF and getting more and more disturbed. Even the beginning of IPF, people are looking and searching for the options of the lung transplant. I am sure this webinar is going to enlighten the people who are listening that it is not that fearful a condition, and the lifespan is not the way it has been mentioned on Google or into the papers. Our experiences we are going to share here. Before getting into the panel discussion, I will like to invite my fellow panelists today, Dr. Naveen Dutt. He is professor in AIMS Jodhpur. He is member of ACCP, ICS, ERS, and APSR. His major achievements are ERS Fellowship in ILD at University London Royal Brompton Hospital, Indian Sweden Healthcare Innovation Award, authored and peer reviewer in several national and international journals. He has publications more than 90. Welcome, Professor Naveen Dutt, on board with us.
Thank you.
Next is with us Dr. Alpa Dalal. I met her for the first time in NAPCON 2023 in Delhi, because our trainer of ICS speaks very high about her regarding the pulmonary rehabilitation and her involvement in yogic exercises for the chronic ailments of respiratory medicine. She has approximately 70 papers presented at conferences. Publications, she has 22 with citations 153. She has 2 book chapters to her credit, and she has journal articles to the tune of 18. First prize in research paper on Kriya Yoga and medication in conferences on public mental health and neurosciences in November 2017. Congrats, Dr. Alpa Dalal. Her areas of interest are MDR, XDR, asthma, ILD, and pulmonary rehabilitation. Welcome, Dr. Alpa Dalal. Next is our Dr. Sudarshan Kothal, who is from Odisha. He has areas of interest of tuberculosis, COPD, diagnostic bronchoscopy, medical thoracoscopy, sleep and respiratory critical care. He is the chair of East Zone of Indian Chest Society. He is fellow American College of Chest Physicians, APSR, and he has membership of all societies what we have in the country and abroad, including ACCP, ERS, and WABIP. He is co-author in chapters of 5 books and author and co-author in 31 research articles. Welcome, Dr. Sudarshan Pothal, to the elite panel of panelists. And next is our dear Dr. Shrija Nair, who is, I'm happy to read her biodata done from Delhi. She has done DNB from Apollo, Delhi, and she is now consultant Medicover Hospital, Kharghar BNJ Cardiac Hospital, Kamothe, Navi Mumbai. She is associate professor in charge Sleep Lab, Allergy Clinic, Pulmonary Rehab, guide and mentor to MD, MBBS, physiotherapy, MPT, nursing, MSc, microbiology students. She is member of all societies of our national and the member of ERS, APSR, and WABIP. She has 1 international and 7 national publications. She has poster presentation and being a second prize in poster presentation in APSR. Her areas of interest are all super specialized area of the specialty of respiratory medicine. Welcome, Dr. Shrija Nair.
Thank you so much, sir.
Welcome all of you on board. So I will like to start first with Dr. Naveen. See, we have heard the lucid talk of Professor Yuvarajan. We heard the recorded talk of Dr. Jankaria. So, Naveen, what are the points in history and clinical findings which, if present, will want you to suspect IPF? And you must reinforce the natural history of IPF, what Yuva has said. And if you go by the literature and go by your experience, they say IPF, the longevity of life is 5 years, 3 to 5 years. The literature itself differs on this statement. So I will like you to elaborate on these clinical findings to pinpoint the diagnosis. If you don't have other facilities, even in periphery you are sitting, you are able to give clue to the people who are not in metropolis that they are sure of it is IPF and it is UIP, and to console and tell them the IPF is not as dangerous as the havoc has been made, because we still do not know the phenotypes of IPF. So longevity depends upon the further phenotyping of IPF, which I am sure in the future to get revealed. Please, Dr. Naveen.
Sir, the first thing I would like to say that in our experience at our center, at many of the other centers which look at a good chunk of the ILD patients, the IPF is not one of the main ILDs in India specifically. So if we talk about our center, we have the most common is the fibrotic HP, then the CTD ILDs, even we have more idiopathic NSIP and idiopathic OP than the IPF. So we were planning a study, but we had to shell the idea because we don't have much of the IPF patient. So the IPF is not that common in India. Secondly, there are two type of presentation. One in the primary and secondary care where patient might present clinically only with cough, dyspnea, and fine crepes. So that is in then second presentation is which is seen in the referral centers, the tertiary care centers. The presentation is commonly clinico-radiological. The patients, they come with the radiology, the CT scan, as well as the clinical symptom. So I'll talk from both the angles. So when we are talking about the clinically, the if there is dyspnea, cough, and there are fine crepes, basal crepes bilaterally. So that is one clinical scenario where we should be suspecting the ILD. So as there are the crepitation, they are basal and bilateral, and if they are velcro crepes, the first diagnosis that comes to mind is IPF. Now, because we are just talking about clinically, we need to rule out the other common causes of ILD. So with the history, we should be ruling out the environmental exposure, the pigeon exposure, the mold exposure, the damp walls, and then the sign and symptom of connective tissue disorder, then the occupational exposure, then history of intake of any anti-cancer drugs, any anti-rheumatic drugs, any the anti-arrhythmic drugs, and the antibiotics. So if these are all negative, even on clinical suspicion, the first diagnosis will be the IPF. Then in the tertiary care setting, the patient will be coming with the symptoms and the CT scan. So the in such a scenario, the radiology picture matters a lot. So if there is bilateral fibrosis, so the main cause of fibrosis in India is tuberculosis. But we are looking at the systematic the fibrosis of ILD. So architectural distortion and the volume loss, they can happen in ILD as well as the post tuberculosis fibrosis also. But we need to look at the reticulations, the traction bronchiectasis, the bronchiolactasis, so and honeycombing. So if these things are present, we are sure we are dealing with a fibrotic ILD. So when we are sure that there is fibrosis and we are dealing with the fibrotic ILD, then we need to differentiate whether it's a IPF or non-IPF. That is the first the radiological differentiation we need to make. For that, we need bilateral basal involvement, reticulations, honeycombing. At times, in probable UIP, honeycombing might not be there. So these clinico-radiological things make us suspect a diagnosis of IPF in a patient who is coming with the symptom.
Very nice. What about your experience about the natural history? Because patient when diagnosed with say UIP or fibrotic ILD or the CT ILD, everything is converted ILD into the lifespan of UIP. That is how the people take it. This is where I'm sure you need to give time to the patient and discuss what exactly is suffering from. There is no need to worry. ILD is a plethora of groups, known and still unknown entities, right? So I think very nicely you elaborated. And now I take on to Dr. Alpa. What you will ask the patient to rule out etiology, like everybody, we are stressing now, UIP is very, very clear, classical. Patient has a history of chronic cough. As Yuva has shown, you see the X-ray chest, you see there are basal haze, you suspect there is an issue like ILD, you get into HRCT, typical honeycombing is there without or with traction bronchiectasis, with not pure GGOs, with very mild GGOs. You see the bibasilar crackles, you see the clubbing, undisputedly you put that category into UIP. There is no need of MDD, there is no need of BAL, biopsy, TBLC, or any plethora of investigations. You upfront start the treatment, which we are going to discuss. The problems are with the indeterminate and the other ILDs, which are class 3 and 4. I am sure in the coming time, the Europeans and American are going to merge probable and the classical UIP into the UIP, making them into 3 rather than into 4. So, Alpa, what questions you will ask to rule out other than UIP, and you are able to diagnose this is not UIP, this is other ILD.
So, thank you, Dr. Chawla, for that question. Very important because it's said that now most of the patients who are presenting with fibrosing ILD, the distinction is becoming less and less relevant clinically. But I do not think so, because still a large number of patients present to us in an advanced stage where already fibrosis has happened. And there is definitely, at times difficult to differentiate this on radiology itself. And clinical history is going to be extremely important in this patient. So as our registry data has also said that the more common kind of fibrotic ILD that we see is chronic HP. And in our setting, we are seeing a lot of patients with CTD ILD coming with progressive fibrosis. So these two categories of patients who are non-IPF category, we definitely need to rule out. So in fact, we should make a complete pro forma where we can have all these, questions listed. So for ruling out CTD ILD, we should be asking questions like, joint swelling or inflammation or joint deformity to rule out RA. For ruling out Sjogren syndrome, dryness of mouth, dryness of eyes, so all the Zika symptoms is the dryness of skin. You have to rule out Raynaud's phenomena, mouth ulcers, no motility dysfunction like dysphagia, and skin rashes, photosensitivity, excessive hair loss. Now, all these are very important to rule out CTD features. Then, in case of sarcoidosis, also a kind of disease which presents with fibrosis, of course, there are distinctive features on thing, but in history, we must rule out a patient presenting with lymphadenopathy, symptoms of fever, fatigue, or multi-system involvement is there, then it points more towards sarcoidosis. Another very important group of diseases, which chronic HP, presenting like IPF-like feature on radiology and advanced even pulmonary hypertension. So these group of patients, we need to rule out all the environmental exposure. And this is we have to have an extensive list from occupational exposure like farmer's lung, people working in veterinary setup, and bird fanciers disease. Then commonly patients coming from city, we have to ask for pigeon exposure. And there are many unknown allergens they get exposed, like having moldy walls in the house or, dampness in the house and lot of environmental exposure. In fact, we have many patients coming to us who are exposed to, faulty air conditioner system at workplace or moldy walls or pigeon exposure at workplace. So all this history here of exposure has to be taken extensive. In fact, it is a good idea to make a pro forma with all the exposure history written so that you don't miss out on things. And drug exposure is another very important history, which you say, drug like called amiodarone, chemotherapy drug like cyclophosphamide or bleomycin, or many onco patients who are exposed to radiation. That's a very important history to be found. And his past history of COVID is also very important because many patients with post-COVID lungs are coming with lung fibrosis. So I think all this extensive history would be very important to rule out other causes of who are presenting with fibrosis, but they are non-IPF.
Alpa, great. I think with your discussion, the take-home message is those who are running the ILD clinics, I'm sure they have these performers when they interact with their patients. And for the patient's benefit, for the benefit of the audiences, I will definitely request Alpa to make a good, nice performer through Amita. I think we can circulate it to those who are not running ILD clinic or they want to start the ILD clinic. And it will help them that you don't miss out. Like in sleep disorder clinics, you give it to the patient to say yes, no, yes, no, yes, no. So similarly, in an allergy clinic, you give them the pro forma. So I think it's a wonderful take-home message to have the ILD pro forma in not in the ILD clinics, but rather than in our routine clinic. Whenever we are suspecting ILD, we give it to them to fill up to make the work easy. That we don't miss out anything. Thank you, Alpa, for wonderful input. So I come to our Dr. Sudarshan Pothal, who is the chair in the East from Odisha. What kind of the blood test you advise if you are suspecting ILD? Now I am using word ILD. IPF, UIP pattern, ILD is a classical separate entity, and rest discussion is important for non-UIP. You say the ILD protocols as has been discussed. So what kind of blood test, Dr. Pothal, you will send?
Okay, thank you, sir, for your nice question. Thing is that as you utter the word ILD instead of IPF, actually, as already Professor Juvaranjan already told many things about extensively, just a review here. See, idiopathic pulmonary fibrosis means definitely we need to exclude some identified cause. To exclude the cause, already described my previous panelist about the history and proper examination. Next part is about test. What is the blood test? Particularly blood test required to exclude few groups of ILD, particularly CTD ILD, where we need some basic investigation. Say, for example, many people may be asked that though some group of people having not a clinical features, neither in symptoms wise or sign wise, having without any CTD, should you go for any ILD antibody panel? Yes, because many of CTD ILD may be manifested as a long predominant CTD. What I mean to say, classical CTD may not be there, but patient may manifest it predominantly or earlierly a long manifestation, means ILD manifestation. That's why to exclude any CTD, we need to do some test, basically some basic investigation like say quantitative CRP, ESR, ANA. ANA particularly anti-nuclear or antibody, that too immunofluorescence method, not by ELISA method. It is very important. And some other investigation like a rheumatoid factor, anti-CCP, and so and so. But I mean to say, these are the basic panel for exclude CTD ILD. But if clinically we suspect there is some in addition to, suppose for example, clinically we suspect there is some sort of say scleroderma or systemic sclerosis, based on the history or based on the clinical finding, we may go for the panel and expanded panel of the any test related to that CTD. This is all thing about the test required, particularly blood test required to exclude CTD ILD, and indirectly also to identify our idiopathic pulmonary fibrosis. This is from my side, sir.
Thank you, Dr. Pothal. So, do you think, like, these lab people will visit your clinic with upfront, you suspect ILD, which is non-UIP, and please send for ILD profile, send for hypersensitivity pneumonitis panel. Like this, they have sub-classified. If you go by this, should the patient bear the brunt of all tests to rule out non-UIP ILDs, or here the history will help us to get specifically, I want rheumatoid, I want Sjogren, I want hypersensitivity. So we can always differentiate depending upon the history to go in for these panels and get to exclude other kind of ILDs. Wonderful. Thank you. Coming to Dr. Shrija,
Sir, I would like to add something.
please.
So the issue of the complete the profile is, it has too many issues. One, the cost issue, because if you want to do all the tests, it requires a lot of money. Even HP panel, it might need 10-15,000. Then CTD, if you want to do myositis panel, ENA reflex, then the total expenditure might be 25-30,000. So there are certain subgroups where we do all the testing. If the patient is young, it's not a straightforward UIP. If there is extrapulmonary involvement, if the involvement of pleura, or there is a primary vascular involvement, the FVC, the DLCO impairment is more than the FVC impairment, where we are suspecting, or where we have other members in the family. So we have some family members who have the ILD, so we might need to rule out the familial ILD. So especially in CTD, the workup is very important, because especially myositis and the Sjogren's, the ANA will be negative. In the antisynthetase, more than 50% patient will be ANA negative. In Sjogren's also, more than 50% patient will be ANA negative. So if we have ANA negative, they still might have Sjogren's and might still have antisynthetase. So in fact, we have 20 patients of antisynthetase, which were only picked on the serological examination. They have ILD and the antisynthetase antibody positive. So in the right, radiology is very important. If we have mixture of NSIP and OP, so if we can see ground glass opacity and we have the consolidation of OP, that is one picture which suggests myositis or antisynthetase. Second, if there is the fibrotic OP, we are seeing OP, and in that area we can also see some traction bronchiectasis. So we have dilated airways inside the organizing pneumonia. So that is fibrotic OP. Again, very, very specific for myositis and antisynthetase. These are very clear-cut picture for the myositis-related ILD, and we should be directly doing the myositis antibodies in this subgroup.
So nice. Again, we are stressing upon two things: the history, as Dr. Alpa said, and the radiology on the HRCT and X-ray to lead you to what specifically we send, rather than loading the patient with plethora of unnecessary investigations. What is required should be done. Sure, I am with you, Dr. Naveen. Shrija,
Yes,
we will like you to revise with us the HRCT findings of UIP. We are now traveling between UIP and non-UIP. So we are back to UIP, and what are specifically tells you this is UIP, and out you go. You don't need MDD. You do not need lavage. You don't need biopsy. You don't need cryo. You don't need anything. So specifically tell to the audience, if they are there, it is UIP. Thank you.
Good evening, sir. Thank you so much, sir. I just going to reiterate the points that have already been covered beautifully by Rajan sir and by Bhavin Jankaria sir. So we know that UIP is the typical UIP pattern is the hallmark of IPF. And it's basically the distribution of the opacities will be subpleural and basal. And what are the opacities you see as described beforehand? Honeycombing is the hallmark of the disease. What are honeycomb cysts? Honeycomb cysts are thick wall cysts, which are usually stacked one on top of the other. It may be it may range from 3 mm to 10 mm in diameter, although in literature it has been shown to be even as big as 2 centimeters. But for practical purposes, it's usually small cysts which are clustered one upon the other. It can be one layer, it could be multiple layers, and it's basal, and it's usually bilaterally symmetrical, although like the new guidelines have told us that 25% of cases, it may be asymmetrical too. So there's a caudocranial, that means from the apices to the base, you will see the lesions increasing. There would be minimal ground glass haze. The reticulation is seen along with honeycombing. Yes, we have to talk about the traction bronchiectasis and traction bronchiectasis. So if you have honeycombing with traction bronchiectasis, bronchiectasis, it's subpleural, basal, with a craniocaudal craniocaudal fashion with minimal ground glass haze, we get the diagnosis of UIP. Also, they've mentioned ossification. That means ossification that is seen in areas of fibrosis, and like Professor Yuvrajan sir said, in the bases and in the pleural areas. So this can be seen in up to 29% is what the latest guidelines tell us. And you have other non-dominant features where you may have things like emphysema in the upper lobe, which when it can coexist with a UIP pattern in cases of combined emphysema and fibrosis. You may have pleural parenchymal fibroelastosis pattern too. But as of typical UIP pattern is what I've described with the honeycombing, traction bronchiectasis, subpleural, subbasal predominant.
Thank you, Shrija, for nicely describing. Like undergraduate, you used to see the laryngeal inlet in the books. The day you did your first bronch, you saw actually the laryngeal inlet. You could identify this is laryngeal inlet. You have seen in the book Taj Mahal, you see Taj Mahal, this is Taj Mahal. Similarly, if you have seen this book picture of honeycombing, UIP, and a patient of UIP has come in front of you, I'm sure you will not miss, and especially after this webinar, you are going to be wise and confident treating UIP. And this is what the message we want to give to our audience. You are well prepared more than all of us because you have worked hard. So what condition other than IPF? Like Jankaria was showing IPF and non-IPF CT pictures. He has covered all 1, 2, 3, 4, all kind and varieties. So what you see, the UIP-like picture, in what are the clinical conditions where picture is like UIP, but it is not UIP?
Sir, actually, the pattern UIP is the pattern and the pathology that is, that is different and disease is different. That is the first thing you need to understand. And if you see a UIP pattern, the same type of fibrosis, same honeycombing, you may see in other conditions also. When you label as idiopathic means when no cause is there, then only we label as the name indicates. So before that, we need to have a groundwork. For that, you need to ask exposure history, either organic or inorganic dust exposure or exposure to drugs actually. This is what we have discussed. This typical, similar like UIP pattern, like honeycombing, extensive fibrosis, traction bronchitis, all these things you may get in a common disease, what we see in day-to-day practice, HP. In case of fibrotic HP, you will see a extensive fibrosis, more like you see honeycombing, more in the upper zones, more in the upper and mid zone area when compared to lower zone, what we see classically in a IPF. The picture looks same, but the distribution is different. Sometimes you may have a subpleural basal distribution also in what you see in IPF, you may see a similar picture in fibrotic HP. So next to that fibrotic HP, in asbestosis also you will get UIP pattern. And in a patient with a drug exposure, especially amidrone exposure, and already madam has discussed about other drugs like chemotherapy drugs and all. So this also causes lung fibrosis. Sometimes it causes honeycombing also. That you have to understand. So asbestosis, chronic HP, and sometimes sarcoidosis. In case of sarcoidosis, the extensive fibrotic form. So that also it will have a typical picture. But the area of fibrosis will be different. That you need to see. In HP, the area is mostly in the central zones because I told you HP is a disease that is close to the peribronchial area. So the fibrosis also we expect the centrilobular fibrosis. This is a classical distribution of fibrosis in case of HP. But I'm telling you, this is not the same you see in all the patients. Our patient will be a mixture of all the probabilities. The CT will be messed up. Now you don't get the classical finding. So likewise, UIP pattern other than IPF, you will see in all the situations.
Correct. It will also include rheumatoid. It will include
CTD-ILD, sir. CTD-ILD, rheumatoid, and all these things, sir.
Include into this. Very nice.
And scleroderma also to some extent.
Yeah. Thank you for revising all this. Naveen, back to you. The HRCT finding suggestive of probable UIP. What is the main difference from UIP to probable UIP? What is not there? What is there in UIP pattern?
So, as discussed in the presentation also, if there is everything which makes a diagnosis of UIP, but honeycombing is absent, then we call it the probable UIP. But the issue of probable UIP is still in the right clinical context, if patient is elderly, smoker, male, still there is very high probability of having IPF only. But the issue is the other diagnosis, they increase in frequency. It can be in the right context, if there is underlying CTD, or if there is some antibody positive, it can be NSIP also. Fibrotic NSIP can very well give, because only 20% patient they have subpleural sparing. If subpleural sparing is not there, it's very difficult to differentiate a UIP and the probable UIP and NSIP. So in a certain clinical subset, we might need to do the further investigations. Secondly, if there is probable UIP, then at best we can make a provisional diagnosis of IPF. The confident diagnosis we can't make. The provisional diagnosis, the high confidence provisional diagnosis we can make. That means there is 70 to 90% probability that we are right in our diagnosis. So in this subset, it becomes even more important to rule out all the other differentials, because the probability of having IPF is lesser than what we see in the typical UIP.
Great. So apart from the honeycombing, you will be labeling other features in probable UIP, but still in experience, as UI is also repeatedly selling, all cities are messed up so that you are not able to pinpoint exactly what we are dealing with. It is indeterminate or it is an alternative diagnosis we have to get into, and sometimes you have to proceed with diagnostic plethora in probable UIP also, which is not recommended in guidelines. So here maybe the MDD will help us to reach what we should do and what we should not. So coming to Dr. Alpa to complete this CT classification, HRCT classification, please enlighten us with the indeterminate UIP and the pictures in alternate diagnosis of HRCT from UIP. You are mute, Dr. Alpa.
Yes, so I think already it has been discussed by Dr. Yuvraj and Dr. Bhavin. And just to brush up that here we have category of definite UIP where you can get 90% confidence, probable UIP where at least 60 to 70% confident in making a diagnosis of IPF. And the other side is alternative diagnosis, where you have features of alternative disease. And in between this category, where you don't have classical alternative feature and you don't have classical features of IPF. So typically, apart from honeycombing, even the traction bronchiectasis or broncholectasis or significant fibrosis may be lacking in this category. A classical basilar predominance may be lacking in this. So they might just have reticulation. They might not have classical subpleural involvement, and they don't have classical basilar gradient. So these are the patients where absence of other features and absence of classical features of honeycombing and fibrosis will be determined as indeterminate, and they definitely need to be further investigated and surgical biopsies indicated in them.
So nice. Whatever, apart from the basal honeycombing distorts the architecture of the lung. When you see in HRCT, the lung parenchyma in the lung window is totally haywire. It needs to be worked up, and we label them as either indeterminate or an alternate diagnosis, which needs further workup with the history, and we are going to discuss what is going to help us to reach at these diagnoses. Now coming up, the tissue is the issue. Dr. Sudarshan, so what are the patterns and clinical situations when you will ask for a lung biopsy?
Yes. Thing is that practically as regard to UIP based on HRCT UIP or the probable UIP, these are almost same club together. Rather, natural history of both these groups are almost same. Actually, the level of confidence of UIP based on histology, both definite UIP as well as probable UIP is more than 70%. That's why these group of HRCT finding not required any sort of biopsy. Rather, other two groups, particularly say indeterminate group as well as alternate diagnosis, these groups are as because histopathologically confidence level is very low, means say less than 70%. That's why these groups required biopsy, any form of biopsy, but required biopsy for confirmation. Why these two groups is more important, UIP as well as probably UIP, because the natural history almost same, and also level of confidence is high. That's why whenever you think of once based on HRCT, you are thinking the UIP or probably UIP, not required at all. Not biopsies, neither biopsy nor BAL not required at all. In contrary, rest two we required biopsy.
Good. So we need to have the tissue. Which modality to complete your question, the answer, I will involve Dr. Shrija. What you will like to do? TBLB, TBLC, or video assisted the video assisted lung biopsy? Which clinical situation and what you will like to have?
Yes, sir.
Whether in UIP, do you suggest all of them? Yes or no? No, then what modality we should have for indeterminate and alternate diagnosis of TBLB, TBLC, or VATS?
Thank you, sir. So we do not suggest TBLB, that is transbronchial forceps biopsy, in cases of for diagnosing UIP. The only indication as per the guidelines, 2022 guidelines, of using TBLB is when you do genomic markers that we'll talk about. So genomic classifiers, sorry. But that is another topic. But basically, we don't use TBLB anymore for the sake of UIP diagnosis. Where I would use TBLB still is when we are suspecting conditions such as sarcoidosis or subacute hypersensitivity pneumonitis. So that leaves us with two choices: the cryobiopsy and the lung biopsy, the surgical lung biopsy. In most centers, like even the one I have, we have a thoracic surgeon who's dedicated, and he's doing VATS, uniportal VATS, and lung biopsies are done. Now, if we compare the cryobiopsy and the surgical lung biopsy, there has been a COLDIS cohort, which was COLDIS is the cryobiopsy versus the surgical lung biopsy in cases of diagnosis of ILD. This was done in 2019 in 9 centers in Australia, and we found that from that data there is a good agreement between the results of the surgical lung biopsy as well as the cryobiopsy. So I think it boils down to the fact that what are we comfortable with, and do we have a good team at the center where if cryobiopsy can be done in the center, it reduces the cost of the patient. There's lesser morbidity, although bleeding is a high side effect. About 29 to 30% of patients can have a bleed, which needs to be managed with a balloon tamponade. So, other complication is pneumothorax, which is seen to a tune of 9 to 10%. Whereas in a uniportal VATS biopsy, the higher risk is of infection. There's lesser chances of bleed, and there's a minor chance of air leak as well. So, if we have the expertise, if we have a good team, if you can manage the bleed, I would say, as well as the guidelines say that cryobiopsy is as good as the surgical lung biopsy.
Very nice. Shrija, to add to you,
yes, sir.
They discuss about the number of pieces rather than anything else. So if you have 3 to 5, the chances of your tissue acquired and the diagnosis is good. Chances of bleeding with TBLC or pneumothorax. So if you read about the lung architecture, the vascular area is that you are 1.5 centimeter away from the pleura. When you are taking the C-arm help, you know where you have to have a third of the cryobiopsy. You will be happy that I am the first one who has done with the twin bronchoscopes the cryolung biopsies without rigid bronchoscopy. People recommend rigid bronchoscopy, use the Fogarty balloon and do the cryobiopsy. We put 2 bronchoscopes, one normal 4.8 dia and another the video bronchoscope. With one, we hold the balloon or the segment where we have to take. Another under VN, we go into the segment and pull and immediately under VN inflate the balloon. Indian Journal of Tuberculosis, I can refer to where this paper is published and the technique is published. Soon with our experience of DPLD cases, I am going to publish by doing this twin bronchoscope. I have labeled it as a kissing technique to do the cryo lung biopsies in DPLD cases to avoid pneumothorax and the problem of bleeding. So I am sure this is going to help. Even you have to have an extra skill for rigid bronchoscopy. You have to take the patient to the OT. You need anesthetist trained for the jet ventilation and rigid. Where if that facility is not there, you can have the twin bronchoscope technique and do the cryo lung biopsy.
Thank you, sir.
Your little change. What
sir.
if the patient is incidentally found to have a UIP? And let me contribute. The lungs is such an organ which bears the insult up to 60% before patient is symptomatic, especially for a disease like ILD or the patient has got an UIP or an indeterminate type. It bears, keeps on bearing, and finally he presents. And when he presents and you have an UIP pattern on CT, but patient has no symptoms and has normal spirometry, both TLC, DLCO of 70%, no desaturation on 6 minutes, would you start antibiotics, antifibrotics for this patient or observe? If upfront, yes, why? If not, why?
Sir, we actually, in my talk also, I specifically told that this is actually another fatal disease. That we are not, it is totally unreliable disease because we don't expect the same type of pattern in all the patients. First, it is a progressive fibrosis. Any patient who having extensive or progressive fibrosis, it is almost comparable, outcome is almost comparable to any form of cancer actually. I used to tell the patient like that only. So it's a progressive disease, but you don't know when it's going to progress rapidly or slowly, but it's going to progress definitely. This is not from the single statement I'm telling, sir. This is based on our previous experience and data also. We have a big impulse trial is there. Like they have used nintedanib for, fibrotic ILDs. So in that also, if you see, those patients who got a FEC more than 90% also. So these patients, when they followed the case after 1 year, they have a significant fall in the physiological path. That is, FEC is falling actually on the almost for most of the patients. And the fall rate of fall and the progression is almost similar to those patients who got a FEC less. That means that I'm just refining the statement. Those who so-called FEC is normal at the baseline, after 1 year, you can expect the fall. The progressive fall is there in most of these patients. Not only that, 2.5% of the cases in their group, that is the impulses group, they've experienced exacerbation also in that group. So considering the progression, and the rate of progression is similar to those patients who have a low FEC and the baseline. So seeing a baseline FEC only, don't think that the patient won't progress. They are going to progress. The time will be different. So don't wait for anything. Straight away go for antifibrotics. They may ask one question, sir, antifibrotics, whether it's going to reverse. No, it won't reverse, but it will definitely stop the progression. It definitely makes you to feel better. So that's the thing from my side, sir.
So very nice. So as early as possible, if you detect, you start, whether there is a symptom or no symptoms, please switch on to antifibrotics. We are going to come down which antifibrotic in the discussions, but antifibrotics are the need of the day, and the take-home message is the moment you pick up, you please start. Very good. Naveen, now, if there are two antifibrotics which have established themselves, pirfenidone and nintedanib, correct? So, pirfenidone, before it was not available, it was available in 801 milligram. Now, though it is available in 801 milligram also. It was 200, 400, 600, and gradually companies came down to 801, the proper adult dose of 2000, 400 plus 0.8, whatever it is, right? And nintedanib. 2 tablets, morning and evening. Now, if I'll say pirfenidone, 3 tablets, 2 tablets. How you will start? Because the gastric, number of tablets, stories, patients, how you will introduce pirfenidone to the patient upfront 800, or you will start from 200 to onwards?
So my experience with pirfenidone is not that good because it's difficult in a majority of patients to reach the maximum dose, and we need to do many dose reduction, and then we need to increase the dose. So not the I prefer to start with nintedanib, and if there is some issue with nintedanib only, then I start pirfenidone. But when we start it, we start gradually. First 200, 400, 600, then 800. So every week, or maybe in certain patients every 2 week we do it. We monitor LFT and then increase the dose. And one important thing, it has to be given with the meals. Although the bioavailability decrease somewhat, but the side effects, they are lesser. Patient tolerate it better. So it has to be introduced gradually, and then if we are able to reach the full dose, it's a good therapy if we are able to reach the full dose. But in my experience, it because it takes a lot of time to reach the full dose.
Correct.
So that is the issue with the pirfenidone.
So your choice of nintedanib was also at that time when it was costing 1,35,000 rupees to the patient and to the doctor 65,000 rupees. You used to use at that time also Sindanib, or you were happy with the pirfenidone at that time?
So at that time we used only when the pirfenidone was not working or there was side effect, because it was very costly. So, but now we have both the drugs, they priced at almost the same level. So we have luxury to use either of them. So I prefer nintedanib first. And if there is some issue, then we go on to the pirfenidone.
Correct. Very nice. Very nicely. Alpa, what are the side effects which are making him afraid using pirfenidone? We will come on to the superiority. Pirfenidone or nintedanib or the same. But the thing which is making him afraid, what are the side effects of pirfenidone which you want to avoid and simplify to nintedanib?
So, yes, for pirfenidone, though it's a good antifibrotic drug, but quite a few number of patients end up having ADR. Now, this ADR is most of the time mild to moderate, may just require temporary stoppage of the drug or dose reduction. Sometimes it can be pretty severe that you have to permanently discontinue the drug, and at times, and very few incidences, that it can be life-threatening. So the common ADR that we see with pirfenidone, the commonest I would say nausea, loss of appetite, and extensive fatigue, and photosensitivity and rashes. So these are pretty commonly seen clinically. And so most of the time these would be mild, but I would say quite a few number of patients, at least 20 to 25% of the patients, we may have to discontinue it for a while and go for dose reduction. Liver hepatic injury is another thing which is pretty common, and that is the reason why periodically we need to monitor the liver functions with these patients who are taking pirfenidone. And in patients who have got pre-existing hepatic disease, one needs to be pretty careful. And these patients, they can have, they have extensive rise in the liver enzymes, and we may have to discontinue this medicine. And we've seen that sometimes the patient may have just vague symptoms like headache or feeling unwell or just losing weight. Now, this is also, we have seen that sometimes patients are just losing weight on pirfenidone. And and at such situation, we have to take a decision whether by giving antifibrotic and, retarding the progression of the disease, and on the other side, if patient is having severe anorexia and nausea and extreme fatigue and losing weight, the patient is losing muscle mass and having very poor quality of life. And then we have to really take a hard decision of stopping the medicines and just giving the supportive treatment to this patient.
Great. Thank you, Alpa. There is a question from audience, Sakshi Batra from Delhi. She wants to ask Yuva, the intractable cough, which bothers to the patient, how you manage in spite of the cough suppressant?
Sir, actually, there are a lot of agents have been tried. As you see that it is comparable to malignancy only. Malignancy, we use opiates, sir. We use low dose opiates. And there is one more molecule available in market is benzonatate. That is a local, that is, and the brand name of Benzpyrs as the local alveolar, airway anesthetic agent actually. And there are suppressants we can use, sir. Anyway, there are certain group of patients, whatever you do, they'll complain of cough, sir. Because they may have a reduction in intensity of cough, but the aggressiveness, the frequency may reduce, but intensity of cough may be there in same patients. And once you do give antifibrotics and you do a holistic approach, definitely they have a symptomatic improvement. The thing is that we have very few options. Cough suppressants, commonly whatever you're using for other condition, we can use. We can use benzonatate. We can use opiates low dose as a form of terminal pricing.
Very nice.
So I would like to add one thing here. Can I?
Yeah, please.
Yeah.
Yes.
Yes, so sometimes we see that patient is not progressive radiologically, pulmonary functions are not dropping, and the cough is there. It's a time other causes have to be ruled out, and this patient have reflux very commonly, and that can be a cause of cough. And many of these patients have left ventricular dysfunction and have fluid overload. So these other causes of cough should also be ruled out in patients.
Yeah, before actually giving all the symptomatic treatments, sir, every clinician should rule out all these things. Because I got a patient with the TB in a patient with PF. So all these things, if there is a pattern is totally different and not fixing with that, then you have to rule out other things which causes cough.
Okay. So I think this is wonderful. You are, and before you are, I think it is Dr. Sudarshan's turn, that nintedanib's side effects. And before side effects, there is a question from Mansoor, Maharashtra. How often, Dr. Ponthal, to repeat the PFT in IPF patients?
Actually,
lot of questions we are answering in our discussion, but there are few which I think need focus. So in between, I keep on addressing. So how often we do, and then we discuss side effects of nintedanib.
Right. As per the recent protocol guideline in 2022 ATS guideline, PFT frequency ideally to be done every 3 to 4 month interval. This is the first question. Second question about your nintedanib. Yes, nintedanib is a better drug, I think, as regard to adherability or compliance of the patient is required in compared to porphyrin. But most commonest side effect is diarrhea. It's hardly about, say, roughly more than 50% cases. And upper GI offset like nausea, vomiting, so and so. But these symptoms are usually mild to moderate, can be managed with symptomatic therapy, as also at times also after giving, say, 2 to 3 weeks, so symptoms automatically subsided. However, some group of patients that having some hepatitis, as already described by the other porphyrin like that also. The hepatitis also, again, is the hardly, say, mild to moderate, not that much severe. Hardly in addition to important side effect where, of course, because this is one of the triple tyrosine kinase inhibitor, that's why the chances of risk of bleeding is little bit high as compared to normal healthy human beings. That's why if a patient having some anticoagulant therapy, we have to more vigilant by doing this, by giving the nintedanib as regard to vigorous monitoring and so we require particularly this group of patients.
Thank you, Dr. Sudarshan. Shrija, which of the two, supporting pirfenidone, supporting nintedanib, and why you will prefer, and which you in your practice do and why?
So before we had nintedanib at an affordable price, we used to use pirfenidone. The only issue that time was the high pill burden. And patients could never reach the dose of 2403 mg. But so we did see good effect even with a lower dose. And recently a study was done in Korea which showed that a dose of less than 1800 mg also gives the same benefit as a standard dose of pirfenidone in IPF. So I think it boils down to now we have 801 mg tablets. So pill burden is not much of a issue, but definitely the upper GI side effects I found are more in pirfenidone, whereas diarrhea is more in nintedanib. Even then, it's easier to start nintedanib. That's what I found. But in sick patients, patients of hepatitis, patients who have alcohol abuse, patients who are on anticoagulation, those patients I try to avoid. I don't avoid giving nintedanib and start the patient on pirfenidone and keep close monitoring. So patients who have history of rash, photosensitivity, it's better to avoid nintedanib and start pirfenidone. And since we have more indications now with nintedanib for scleroderma ILD and other fibrosing ILD, I think that's why we tend to use nintedanib more as compared to pirfenidone. And that's my experience.
Thank you, Srija. We are going to enlighten you also. We are coming down to the system now. Naveen, there is a question from Venkata Krishnaraj, Tamil Nadu. Any role of immunosuppressants, MMF or azathioprine in IPF?
Sir, I think I'm trying to answer. I have answered many questions in the chat itself, but no, the Panther IPF trial clearly suggested the immunosuppression increased the mortality in IPF. So till date, no role of any kind of immunosuppression in IPF.
Very good. So now Shrija left the nintedanib in one set of patients and pirfenidone in another set of patients, seeing what is the history and which patient she should use. Patients are mentally different of IPF. They will come and ask you the nintedanib and the pirfenidone. Both mechanism of action is different as an antifibrotic. They work from different cycles as an antifibrotic. Can combination help the patient to reduce more, or whether you have used combination therapy, or literature supports or does not supports combination, that you choose and use either of this? Both are having the same effect or both are little different? Very precise, give message to the audience.
Hello, sir.
Naveen. Shrija?
Sir, yes, sir. I'm there. Sorry, this video is gone. Yes, sir. So I have not used combination, but there have been studies which show that using a combination of pirfenidone and nintedanib do not have, although the side effects may be increased, but it is the safety profile is tolerable in patients where you can use nintedanib and pirfenidone. So I think that is the way forward because both of them have a different pathway of action. Pirfenidone inhibits the TGF. The transforming growth factor beta, whereas you have nintedanib that works on the vascular endothelial growth factor receptor, the fibroblast growth factor receptor, and the platelet-derived growth factor receptor. So I think combination is the way forward, and there are trials going on for this. I personally have not used it yet, but we'll think of this in the future.
Naveen, what is your experience?
Sir, can I add to it?
Yeah.
So, I have accidentally used dual antifibrotics. So they were started outside, and the two patients they were coming to me. So I didn't stop them. I just because they were doing fine on them as far as the side effect profile is concerned. So I gave them for 3 to 4 months. One patient stopped using both the antifibrotics after 3-4 months because of pain abdomen. And then another patient also stopped the pirfenidone after 6 months. So the rate of side effects, as is evident from the literature, is more as compared to single antifibrotic. But I don't think right now there is some indirect literature to suggest the FVC decline may be even more. The dual antifibrotic can prevent the FVC decline more than the single antifibrotic, but we don't have clear-cut evidence right now that they should be given because we know the side effects, they are significantly more.
So presently we give message to the house and the masses that there is no benefit of using both antifibrotics in the same patient. Choose one. Both are equally good. Both have got different set of side effects. If the dose is 2403, with nintedanib 150, as Shrija has enlightened us with 1800 milligram and 2403 milligram is as good as it is. but choose one at present. Let us see what literature comes and supports combination of this in the near future. I'm skipping Sudarshan, your turn, but I want to come to Alpa to listen about the pulmonary rehab and the advice for nutrition and how to keep your patients physically and mentally active so that they remain upright, they remain mentally healthy, how you do by your yogic kriyas and how you help. This is what I wanted, so I skipped Ponthal. He will excuse me for it because the time is running. I wanted to listen to him,
Yes,
and
yes,
all
yes.
of us
No
want to
issue.
listen.
No issue, sir.
Yeah, so yes, so I think this is very important. When I tell my patient that the lung fibrosis or the CT scan or whatever reports are there, you look at it and get stressed, but there's nothing you can do about it. But there is something which you can work upon, like work on your nutrition, work on your conditioning, work on rehabilitation, change your mindset. So, irrespective of what stage of disease you are, you can definitely change these factors, and that is what is being done. And I think we do it in a large number of patients, working on their nutrition, working on rehabilitation, and getting them into positive mindset with a yoga and meditation. And I've seen tremendous results in patients. And what goals you set for, like you can't set goals of improvement in the lung function or improvement in the CT scan chest, but if you can improve their 6-minute walk distance to some extent, even not that, and you can improve their activity of daily day-to-day living, then also it's a great achievement. And let me tell you, apart from all your other medication that you give, this is something which makes your patient the happiest. So we have, I can give you an example. A patient had come from MP, and he was diagnosed with lung fibrosis. On this, not much efforts were put, and there was classical, fibrotic pattern. He was told that he has advanced lung disease, and he was referred for lung transplant. And he came with a BMI which was much less, and cachexic. We walked up. It turned out to be CTD. We involved the metabolic physician in our hospital, and we did it bone density DEXA scan. In that, we come to know about the muscle mass. We came to know about the bone mass. Both were low. We did his ferritin levels, iron level, B12, vitamin D, and proteins. Okay, and he was severely nutritionally depleted. We started him on nutritional supplement. Along with that, he was introduced to exercises, and now 6 months down the line on medication, he's gained about 10 kgs of weight, and his activity levels have greatly improved. And this is what we do for our patient. Yet there are a lot of challenges because our ILD patients are much more sicker than the COPD patients. Many of them have, have lost their muscle mass. They are underweight. They are using oxygen. They are more tachypneic. So there are challenges, but we make our patient do exercise even with oxygen, and breath retraining, strength training, and aerobic activities. And we see a great improvement in these patients, their mindset, their activity levels, and that itself helps to improve their immunity and helps to reduce the incidence of secondary infection. That is one thing. Other thing which we have been trying and which is working very well, that there are many patients who are unable to come to the center for doing a dedicated pulmonary rehabilitation. And in these patients, we send either a rehab therapist to their home, or we communicate with the yoga therapist, because yoga is very culturally accepted by all the patients and yoga therapists are available. And by communicating with them, we ask them to do some light exercises, and few patients have improved even by doing home yoga sessions. Okay, so these are the various ways we try to work on the patient. For nutrition, as improving their protein intake, improving their calorie intake, and improving their muscle mass through nutrition. So we've been trying some amino acid supplement which helps to improve the muscle mass, and this has also been very effective in our ILD patients.
Thank you, Alpa, for enlightening I request all panelists, please keep on answering yes or no questions which are coming in the chat box to help me, because there are so many questions I cannot individually pick up, and they have already been answered. Few yes and no needs. Please keep on doing that. I am coming to the last round now. So what you Sudarshan, what you will be telling us about the newer molecules of IPF which are in pipeline in phase 2 trial, and there is a very promising molecule from BMW, Bristol people, Mayor Squibb, are coming out with one molecule, then sarcatinib anti-cancer medicine, which is being in the now third phase of the trial for IPF as promising molecules. Please enlighten us in short and brief about these newer therapies which are showing us the light at the end of the tunnel.
Sir, important thing is that one molecule which very often one of our participant also given their question about treprostinil. Treprostinil is a phosphodiesterase 5 inhibitor where it is a inhaled form. It has been seen that it is very much useful in pulmonary arterial hypertension or pulmonary hypertension in ILD patients. Based on that input, in phase 3 trial is going on. Second part is also some, like as we have discussed the perfidone. One of the problem with perfidone, oral perfidone, is that the number of tablet is capsule is more, and second is also about the side effect tolerance, availability or compliance is less. That's why people also trying to do about inhale perfidone. So inhale perfidone at times also, or now phase 3 trial is going on. This is the two important trial. And also one of the important trial is particularly say phosphodiesterase 4B. Again, in the oral form, it is also phase 3 trial is going on. This is almost major trial, and the rest of trial is almost like as you told about some antibody against connective tissue, where there is almost trial is stopped due to safety profile is concerned.
Wow, great. So just to count, there is BMS 986278 molecule in the phase 3, sarcatinib. This is from the Astra, that is from the Bristol Myers Squibb. There are molecules which are PDE4B inhibitors. The recent article in New England Journal of Medicine. There are microRNA molecules which are there as promising molecules, and there is new drug which is coming up. They are putting in increased trial. Tyvaso is another molecule which are very promising for the newer therapies of IPF, and people were very much interesting to ask repeatedly pulmonary hypertension. The guidelines have come before. We were of the opinion there is no need to treat pulmonary hypertension in IPF, but now it is a clear-cut guidelines with treprostinil that you use this molecule with pulmonary hypertension in IPF. So, Shrija, we will now coming on the last round, as I said, about the lung transplant in IPF. Shrija.
Yes, sir. So we consider, first of all, when we come to lung transplantation, I think every patient who comes to you first should be, given a talk about lung transplantation, how their quality of life would improve after lung transplantation. But when we consider a patient for lung transplantation is when we know that the patient is going to have a, high mortality rate, and less than 50% mortality rate in the 2 years to come, whether the patient has more than 80% survival rate after transplantation the first 90 days and 80% survival rate for 5 years, considering his other medical conditions. So first of all, we have to rule out all the factors that tell us that the patient cannot go for lung transplantation. That means a patient of morbid obesity, a patient with uncontrolled CAD, a patient who is non-compliant with treatment. Such patients, and there are many other things that we have to consider. So such patients who have severe psychiatric manifestations, patients who don't have social support, such patients you would not consider for lung transplantation. But if a patient has upfront, if a patient has a forced vital capacity less than 80, DLCO less than 40%, a patient who has on 6-minute walk test walks less than 250 meters, has exercise desaturation, oxygen SpO2 falls less than 88%, either at rest or on exercise, a patient who has pulmonary hypertension. These are patients at the start you consider that the patient should be referred for lung transplantation to a clinic. And furthermore, you will consider a patient who is worsening on the disease. So upfront, you start the patient on antifibrotics and you follow up the patient after 4 to 6 months. If you feel that the patient is worsening, he's had an episode of admission which because of pneumothorax, admission due to acute exacerbation of IPF, a patient whose FVC is declining more than 10%, a DLCO which is declining more than 15%, his 6-minute walk test has worsened over the past 6 months. If there's desaturation and pulmonary hypertension that is developed, then these patients definitely have to be considered for lung transplantation. So, other than that, I think first we talk about referring for lung transplantation, also the waitlisting of these patients for, getting into lung transplantation. So I think these criteria is also given in the guidelines for heart and lung transplantation, Society for Heart and Lung Transplantation too.
Thank you, Shrija, for enlightening for this now. I think it's already more than 2.5 hours. I do not know the login which are still there with us. I will like to close with take-home message for the treatment of UIP, non-UIP from each one of you. Before I close the session, I will start with Naveen being in AIMS, and I will like him to add also his experience of lung transplant in ILD patient with his closing remark.
The results are very good, but the timing is very important. It has to be done at appropriate time, because when the patient is admitted in the ICU with the exacerbation, the transportation of the patient becomes very difficult. You need to put the patient on ECMO, then you to airlift it. So the timing of transplant, it has to be communicated to the patient quite early in the during the management of the ILD. So that, because we have seen every family takes at least 1 to 2 years of time to decide, okay, we will go for transplant. So if we initiate the discussion early, then the results are good. But if we are doing it at the time when patient is already in ICU, patient is on LTOT for a year and admitted in ICU for exacerbation, the results are not good, and many patients, they are not able to, even we are not able to rehabilitate to the for the lung transplantation even. So I would like to ask one question from Dr. Alpa. So what sort of exercise do you prescribe to the patients? And if they are performing them well, how do you escalate the level of exercise?
Basically, I think first thing that we start in this patient is breath retraining. Because unless their breathlessness comes down and they learn the breath pacing, they are not able to do the other form of exercises. So first 1 or 2 sessions are worked on stretching, flexibility, and improving the breath training. And then once they are comfortable breathing, then the aerobic and strength training is added. This is how it's saying. And as they go on improving, then they go on improving the number of repetitions and the duration for which they do aerobic exercise. For example, say cycling or treadmill walking, and targeting their target heart rate and monitoring. And many of these patients with oxygen.
Okay.
Thank you, Alpa.
Thank you, Dr. Alpa.
Sudarshan, your closing remarks and message to the audience.
Yes, sir. As regard to IPF is concerned, again, history is more important. That progressive breathlessness, dry cough, and age of more than 60 years old, male, smoker or current smoker or ex-smoker, having clinical features of clubbing and bilateral velco crepitation, suspect probably it is a case of IPF. We have to do the HRCT again. HRCT is a cornerstone. Based on the HRCT distribution and finding, we can proceed any further investigation like any biopsy required or not. After all, After all, antifibrotic is the main key of therapy. As quick as possible, as soon as possible, we have to start it. This is my take-home message, sir.
Thank you, Dr. Sudarshan. Shrija, what is your take-home message to the audience?
I think I won't repeat what others have said, but to add on, I think we should also look at the comorbidities, like ma'am also suggested. OSA is something that we missed out. GER, gastroesophageal reflux, is something we have to look into. Pulmonary hypertension and cardiac cardiac comorbidities. I think all this should be managed, and early lung transplantation advice should be given to all patients. So,
thank you, Shrija. Alpa, your comments.
So apart from what other panelists have said, I would say holistic approach is very important. You should ask yourself a question. One, you have done enough investigation to reach to a conclusion that yes, it is IPF. Second, you have ruled out all the comorbidities. You're monitoring the disease well. And then you must work on the nutrition, and that's a very important aspect. And nutrition and rehabilitation in whatever form is going to definitely improve the quality of life of your patients. And this is what I think holistic approach is extremely important. There are many youngsters in this group, and many times we just get focused on the drugs because they are easily available to us. But writing the drugs is a small part of your ILD management, IPF management, and you must have a holistic approach for your patient.
Thank you. Yuva, final.
Yes, sir. Actually, as a point to add, like as already everyone told that it's not only the drug is going to work, because anyway it is not going to reverse the condition. We are just prolonging the decrease in the FVC. Along with the drugs, other parameters also you need to think. And one message, strong message, I need to tell to everyone, those who are hearing this webinar, is that I could see many prescriptions of giving a pH related drugs for patients with IPF. Those patients with IPF having pH, actually, none of the drugs is approved except for the one we are discussing, the inhaled treprostinil, that improves excess tolerance. Other than that, other drugs, whatever we use, bosentan, ambrosentan, sildenafil and all, it is actually drastically worsen the scenario only. It may look good actually if you add the drug. But those patients with severe pH also, in patients with IPF, you need to rule out other cause for severe PHT. If you think that IPF is the only reason for severe PHT, if you think that hypoxic pulmonary vasoconstriction is the pathobiology of that, don't trigger that. Don't disturb that actually. If you disturb it, then it will disturb you with the hypoxemia and rapid worsening. So that's a message, strong message. Just because in market you have a lot of drugs for pulmonary hypertension, these people push up the drugs, all the pharma companies and all. Don't use any drugs. Use the holistic approach as all we discussed. Until treprostinil is available, none of the drug can be given for the IPF.
Great. So to conclude, you identify the position correctly, I'm sure.
Can I add one more thing?
Yes, Naveen, you are welcome.
So what I feel in the hindsight, especially for the residents and the people who have started career early, so there are two antifibrotics. They should be starting with one. Get comfortable with one. You will get opportunity because both the drugs, they have significant proportion of side effects. So they'll get opportunity to prescribe the other, but it's always good to get comfortable with one drug first because there are significant things which we need to monitor. There are many side effects we need to monitor for them also. So it's always better to first focus on one and then move on to the second drug.
Good. Thank you, Naveen. So now to conclude, all of us are sitting. I am sure the wisdom has prevailed, hard work of the panelists, moderator, the speaker has given the insight into the UIP management and diagnosis. I'm sure you are wise now how to diagnose UIP, how to treat UIP, how to address the side effects of the drugs and which drug to choose, how to choose, when to have the side effects, which drug to use in pulmonary hypertension, steroids not to be used if this is and not an UIP, you don't have to use the steroids. They have no role, no ball, no biopsy. If a clear-cut case of UIP, indeterminate and others, you need to have plethora to diagnose the type. Architecture is totally disturbed, you need to diagnose. So I am sure you will take home plus the holistic care, which is very, very important apart from the medicines, to be followed and imbibed in your practice. And I'm sure you will have a pro forma which we will prepare and circulate to you to keep it in your clinic when you are taking the history, which is very, very important. So with this, I think I say goodbye to you now and closing this webinar. I am hopeful people have enjoyed, but I have definitely enjoyed with the panelists. Thank you.
Thank you. Thank you. Thank you, sir.
Thank you to all the panel participants too.
Thank you, sir.
Thank you.
Thank you.